The Zuma-3 trial presentation at EHA will be an encore presentation. The data will be presented at the American Society of Clinical Oncology meeting this Friday. We'll be sharing the results of the Phase II study, or Phase II extension of Zuma-3. This is a multi-center international study using CAR T-cell immunotherapy with the CD28 co-stimulatory domain in adults with multiply relapsed and refractory acute lymphoblastic leukemia. We treated adults up to the age of 84, with median age was around 40, and this was a heavily pretreated population, so many of the patients that had prior Inotuzumab, Blinatumomab, allogeneic transplant, and the like, and many came on with very high blast burdens. The median was around 65% or so. The patients received a single infusion of CAR T-cell therapy. This followed sort of a standard lymphodepleting therapy with fludarabine and cyclophosphamide to help keep patients' disease well controlled while the manufacturing was being performed. We also allowed for bridging therapy. It was one of 6 or so defined bridging therapy options. We enrolled 71 patients. We were able to treat 55, and we present the results of in those 55 patients. We demonstrated a composite complete remission rate, so this is CR and CRI, of 71%. Of this, true CRs were around 56%. Nearly all of these remissions were MRD negative. So more specifically, 97% were MRD negative. There was one patient where we didn't have a follow-up to assess MRD negativity. This translated into, extended median overall survival. So it was 18.2 months overall. And in the group that who achieved a CR, we haven't yet reached the median overall survival. This also translated into, extended duration of response and the like. I think the big key takeaway is we were able to do this safely. We did experience 2 related deaths on this trial. One was a case of cerebral edema with brain herniation, and one was an infection. These 2 mortality events, though, were the only ones attributable to this therapy, and I think that it really stands out. We did see CRS and neurotoxicity, grade 3 and 4, in around 25% of the patients for both of the toxicities, respectively. But apart from these, from this one case of CNS herniation, all of the toxicity was reversible. So, for me, the 3 main takeaways are we were able to treat patients safely, and we were able to do so with really high efficacy. Again, extended remission duration, extended overall survival. And so, this is, when we think about this population, again, this heavily pretreated population with high tumor burden, I really think that these results are unparalleled. I think that this is better than anything we've seen to date in multiply relapsed ALL. I think the next steps will be trying to understand how to integrate it earlier in the treatment paradigm. You heard me allude to the fact that we treated 55 but enrolled 71. That means that there were several patients who didn't make it to CAR T. And I think we can look at that and very easily see that, infections and thrombosis, loss of eligibility, these were the key reasons why patients weren't able to progress. And when we think about, why is that the case? I mean, these are heavily pretreated leukemics, right? They have very little in the way of bone marrow reserve, very little in the way of functional reserve overall. And so putting that in context, I mean, we understand, I think, that to really translate this into a successful therapy for all adult patients with relapsed ALL, we're going to have to find ways to integrate this sooner. So we're not in the multiply relapse, post-transplant, post-novel agent setting, but thinking about this really much earlier, for relapsed leukemics. And I think doing so will enable us to treat people before they're critically ill. and by virtue of doing so, be able to deliver the therapy in a situation where patients can actually receive it and can benefit from it. I think that one of the caveats to this is this wasn't really so much a function of manufacturing time. And that is something that I like to highlight on. There's always concerns when it takes, 3 or 4 weeks to turn around CAR T cells. In this particular trial, we were able to manufacture CAR T cells with a median of around 2 weeks. This is really incredible, but it also speaks again to just how critically ill patients were when we were attempting to enroll them onto the study. I am really excited about these data. I think that it's going to be a powerful adjunct for managing acute lymphoblastic leukemia. Again, we still have to go through the approval path, and that's still a process that's ongoing. But provided this meets the threshold for regulatory approval, I'm really very eager to integrate it into the therapy for my patients, and I'm really hopeful that it will meaningfully sort of change the benchmarks that we currently have.